Welcome, everybody. My name's Gina Ingerell. I'm from Effective Policy and Compliance. Today, we are going to be having a look at the critical components for NDIS policy and procedure. So without further ado, let's get into that. I'm just going to open up our presentation and I'm going to share the screen with you. Here we go, entire screen. We should be ready to rock and roll. Okay, so yeah, today we are going to look at critical components of the policies and procedures for NDIS. So let's go on without further ado. We'll look at a couple of things. We'll look at the gaps between policies and the compliance requirements. We'll look at the non-negotiables and what the practice standards require of you, which would only be, that is the minimum for what you need to have in your policy. We'll look at policy language versus the indicators within the practice standards language. We'll look at high-risk gaps, the 5 areas that are most deficient in policies and procedures. We'll look at making policies work in practice because that is actually what they are supposed to do. We'll look at the quality indicators and what a strong policy suite should look like. We'll recap at the end of our session. So what's a critical component? So to know what the critical components are, I think people need to be really clear about what critical components, what it actually means. It's the essential part of a system whose failure or compromise would cause the entire system to fail to meet safety standards or fail to meet its intended mission. And that's very much bound into the standards and in terms of their grading or their marking or their, are they compliant? Are they not compliant? And if they're not compliant, what level of compliance would we rate that? And that's because there are some things that are, if they're missing out of a policy and procedure, would determine quite instantly that is a major system failure. Okay, so if, for example, you had a corporate risk or business risk policy and procedure, and there was not one mention in that policy or any other policy you had that you needed to have a aggregated or a big picture process around your corporate risk compliance and quality. If that was missing from the policy, we would call that a critical component failure, because the fact that it is not mentioned in your policy would mean that that is an entire absence, and there we give it a major non-conformity. Okay, so that's one part. But if you were just missing, for example, let's just say the review schedule, the sort of, you didn't have a timing, you didn't have something in that policy. It talked about the big system. It talked about the aggregated register or the software that gathered all that information for you. So it talked about that. It talked about how it has dates in there. But let's just say that it missed a part of that process, which sat underneath that. And that might be about naming perhaps all of those critical areas that you would be managing the risk for. We would not give that a major. We would give that a minor, most likely, if you were just missing one of those areas. It's not the most critical part. The most critical part would be the fact that you have this overarching system and it's going to be your helper in following and tracking all your risk and the timings. So you can see the critical one is the one that without it, the policy falls apart from a compliance and quality standard. Okay, so your policy suite is a system. It is actually a system, and I like to think of it as a pie chart, which is, the 3 parts to the circle. One of them is your policies and procedures. One of them is the knowledge that you carry in your head. And if you don't have any at all, you're missing a major part. And the third one would be those tools and templates. And this is the three parts of being able to approach the idea of having quality and compliance managed well. Okay. So there's three levels of policy. Not all policies are created equal. We've got some policies are created just to satisfy the auditor. Many of the consultant companies out there have developed policies that just satisfy an auditor. That might be what you're striving for, but it certainly wouldn't be what I would see in good operating providers who have great outcomes. Okay. So that is the bare minimum. So if what you want is the bare minimum, that's what you will get from a set of policies that is written just to satisfy the policy, the quality and safety standards, nothing else. So they're not going to be much help in areas where you're going to have questions about how to do something. And what we've got to understand that in the NDIS, we've allowed so many people into the market who have not a clue what they're doing, that it's never been more important than now to have policies and procedures that actually go some way towards explaining to people what they should be doing and what they should be following. So level 2 might be your quality policy. So it's got compliance and it's got quality. So it's better. It's much better because it's not just dealing with you must do this or you must do that. It's actually got some quality management theory and concept in there about always wanting to do better and how we would do better and look at our data and learn from what we've done. So these will be written against the quality indicators, but they'll include real procedures. They might have timeframes and the roles of people and their responsibilities, and they'd satisfy, not just a plain old auditor who's been doing it for 2 weeks and came out of the business development department within that audit company to become an NDIS auditor, but it would satisfy some of the quality auditors that have been around for a really long time or have not been around for a really long time, but have worked and done their time out in the services and the departments of health and the departments of communities and justice, etc. So they really know what they're doing and they've learnt about quality management as well. So that sort of demonstrates that an organisation understands how to meet their obligations as well as just following the dotted line along the road in level 1 policy. And then we've got the third level of policy, and that's got compliance and quality, but it's also got advice. It's advisory. And these are the ones that pretty much dominated before the NDIS came to fruition. We wouldn't have dreamt of only just meeting the standards under which we worked, and we've always worked under them. We would have policies and procedures that would guide our staff and our managers and our boards of directors on how to do their role. And that was really important. And we've lost a lot of that in about 75% of the market. And it is no wonder in many ways that we see so much harm going on in the NDIS market and aged care as well. So this is the gold standard, if you want, of policies. It's compliant, it's quality driven, and it's genuinely useful. So it's written so a support worker could open it up if they weren't sure what to do, and they'd be able to read what was the next thing to do. You could search that policy for the word, which is medication. What do I do? And you should have a really good not only list of procedures, but perhaps you might have real-time, real life examples as well, because people learn by example and story. So it anticipates real situations. It'll tell staff what they should be thinking and doing in some cases where they're stuck. Okay. And this is where the documentation stops being the risk that it currently is, and it becomes your asset. And that's the only policy and procedure that I want. I don't want something to sit on a shelf. I want that policy and procedure to be able to guide my staff and myself if I've forgotten something. That's what it's there for. So there are some non-negotiables with policy and procedure. So what the practice standards actually require of you is a non-negotiable. So for an NDIS policy and procedure package, it must address the NDIS practice standards. It must. But remember, I just talked about 3 levels of addressing that. 1, you just address that and that's about it. And 2, you're addressing that and you've got some quality improvement and quality management and quality understanding. And the 3rd one, you've got the whole kit and caboodle, and you've got some experienced people writing them, and they've given you examples by which you can draw knowledge from. Yeah. So the non-negotiables, however, are those practice standards. It goes, the same thing can be said for aged care. So the aged care policy and procedure, at minimum, it has to draw from the aged care quality standards. Just the same for if you are a dental, I was a dental practitioner before I worked in social services. And if I were still practicing and I wanted to meet the dental practice standards, and that's practice as in it's a practice. So the dental practice standards, I would have to make sure that my policies and my procedures and everything I did in there met those quality standards. The same for GPs and their standards, the same for mental health services and their standards, and the same for there's still drug and alcohol standards. There are so many sets of standards. There are information standards, 27001, which is an ISO standard for information security. There's ISO 9001, which is a management standard. It's for organizations who have large management responsibility, and it doesn't deal with specialized services, but NDIS providers, when they're very large, and let's say they have 50 or 40 outlets, they're a good candidate for the ISO 9001 management standard, because the management level required with 50, or 40 or 20 or even 10 outlets, depending on their size, is enormous. So that will flourish on a set of standards to assist with quality of your management as well. So non-negotiables for NDIS are the practice standards. So knowing the difference. So your policy states your organization's position and its commitment to a topic. Most providers have this. Yeah. Bottom line policy and procedure. Sometimes there aren't real procedures, is what we notice. We'll see these policies, we'll see a list of something that's trying to be a procedure, but we won't see real procedures. Or there'll be procedures that don't speak to your organization and the way your organization functions, or maybe even the way your organization delivers services and the services it has. Because if they're bought off the shelf, they sometimes won't. And there's nothing wrong with buying off the shelf. You've got to be wary about which policies you buy. So far fewer have this well done. So it's we run around and we talk about, hear people talking about policy and procedure, and I don't think that a lot of people stop and think it's a policy and procedure. So once upon a time, it was before 2012, we used to have a lot of policy and procedure. I worked in aging, disability and home care before NDIS. And that organization was large, of course, and there was one in every state. And they commissioned a piece of research from a consultant company to do a study on how the hell can we get these, thousands of people that work for aging, disability, and home care with the clients in their supported independent living homes, etc. How can we get them to read their damn policies? And they came away, and for what must have been a couple of $100,000, they published a report which was, well, first of all, try cutting them down. And second of all, make them relevant. Don't feed them a whole lot of poppycock, which they don't need to know. And third, make it a policy statement and then a procedure, what to do. So that is that I still function that way. Policy, this is the policy. This is our policy. And here is the procedure to make that happen. Yeah. So, you know, when you say policy and procedure next time, think, oh, yeah, it's supposed to be a procedure too, policy and procedure. We also want to have some work instruction in there. It's really important to have work instruction because how else is anyone going to know what to do unless they're really experienced and or they wrote it themselves. So we really do need to have instruction, and there isn't any, there's no guesswork needed for why we have so much harm and why we have, I'm not going to speak to the fraud, but there's no guesswork for why we have so much harm, why we have so many poor outcomes, and why we've lost an enormous amount of informal support that we once had. And everyone is so dependent on an NDIS plan and therefore rendered desperate and without service if they don't have an NDIS plan or the plan runs out of money because we've lost a lot of instruction that was in there. It was just an accepted practice that we would create these circles of support for people. It was accepted practice that there would be something that our service would deliver, but we knew that 5 or 6 other services were going to need to join our party, and we all did our job. But now we've got more, something that looks more like, well, we don't even know. It would be what we would see in some areas, that people don't even know that that is the way that it needs to be, building people's informal supports as well as their paid for supports. So we've got an enormous load of people who don't have services and have lost their informal supports as well. So we used to have this laid out very clearly because they were in our quality standards from, before the NDIS. And it's what you learn when you study social work, when you study, community services. You learn that this is how we need to support a person. It takes a whole range of services to do that. And when you've got no money left in your plan, you're stuck. So what do we do when there's no informal services left? It's getting more difficult. So knowing that these things are all outlined, I don't want to have to count how many support coordinators I come across for whose contribution to a plan and a person has been somewhat just to diminish the funds and then leave that person with actually no real informal supports or circle or network of people. I really do tire of seeing that over and over again. We need to create these policies, procedures, work instructions, and environments where we are continually trying to find ways to build people up and make their social circles and their health, health prevention circles bigger and bigger. Work instructions do that. Work instructions help people to know what they're doing. And I'm not seeing a lot of people reading their policies and procedures. Um, so don't, so these are not the same thing. And getting the policy mixed up with the procedure, mixed up with the work instruction, it is a mistake. They are all different things. Policy and procedure is not just one thing, it's meant to be two things. A really good policy and procedure will also have work instructions in it as well, or you may have them separately. I've always found, as a quality manager for over nearly 30 years now, that if you separate out a document, it is more likely to get lost from its herd. So I've learnt not to separate out documents too often, to try to keep them together in their herd, so you can't lose them from employee who leaves to the, and from a OneDrive that gets lost, or, there are so many ways it can happen. So I'm very pedantic about trying to make sure that things are clustered together, just like the client really clustered with their informal and their formal supports. So the policy language is really important. So policy language versus the indicator being the main thing that people think is we're writing a policy and procedure so it meets that quality indicator in the practice standards. But yes, and we've covered what we could do in addition to that already. So let's just have a look at policy language versus indicator language. So the quality indicator, for example, so I'm going to give you a few examples here. The quality indicator 2.1.A, the practice standard, and this is it verbatim. Each participant is provided with information on how to give feedback or make a complaint, including avenues external to the provider and their right to access advocates. There is a supportive environment for any person who provides feedback and/or makes complaints. Can't tell you how many times we see a policy that captures that verbatim. No work has gone into that whatsoever. So when you're looking at level 1 of that, we could say our organisation provides each participant with information on how to give feedback or make a complaint. The same thing, okay? It's the same thing. Let's look at level 2. Each participant is provided with information on how to give feedback or make a complaint, including avenues external to the provider and their right to access advocates. There is a supportive environment, blah, 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 blah. And level 3. Both level 1 and level 2 appear in the same document. The same obligation is stated twice. Neither time has either of them told anyone what to do. So this is one particular example of a set of policies which is out on the market being sold, and neither one of them tell you what to do. They're just saying the indicator, which is what the government is saying. We want you to strive towards this being the status quo. But some auditors are accepting that. And that's just the biggest red line, the biggest cross, the biggest everything. I mean, the feedback should have started 6 years ago. Go back and write your policies properly, or tell the people that you bought them from to write them properly. Some providers have paid hundreds and hundreds and hundreds of dollars for policies like this. And any auditor, and a lot of auditors are not allowing that anymore. And I'm really pleased about that. And the thing is, though, that more auditors need to know their job and do their job better, and more consultants need to get that feedback and pull their finger out and write their policies properly. And more providers need to put some effort into it and know that just purchasing something off the shelf and never looking at it does not make you a good provider. So what the indicator actually, demands. The indicator sets out the outcome. Your policy states the commitment, and your procedure will tell your staff how to do it. Again, the quality indicator in the standard, whichever standard, indicates what the outcome needs to be. Your policy will say what your commitment is and how that will work in a brief way. but your procedure will say how. Procedures are best in dot points, in numbered um, numbered bullet points, in flowcharts. Flowcharts work beautifully well. I did do when I took a really large aged care organisation from the old aged care standards to the new aged care standards back in 2019. And I did a bit of research around their staff, and the staff were more receptive because of the English as a second language in some of those homes, not in all of them, but in some of the residential facilities, there were more clusters of staff whose second language was English. They said the diagram, whereas the others were fine with dot points. It really matters who your audience is, and it matters, and it will be to your own benefit to make things readable and understandable according to the different characteristics of your staffing. So we're looking for a policy to, commit. What's your commitment? And then secondly, how your staff are going to do it. So how and when are participants told about their complaint process? That goes beyond the indicator in the quality standards. We need to know how and when a participant is told about the complaint process. In what format will they be told? Verbally, easy read, via their support coordinator. Maybe it's a video that you've made. Maybe you're putting on a pantomime, a puppet show. It doesn't matter as long as you say how, what all those different options are for different people. What happens if a participant lacks the capacity to self-advocate? You have to think about those. They're required in there, not just some blanket statement, which is copying and pasting from the quality standards. What happens if a participant lacks capacity to self-advocate? How are you going to manage that? What are you going to offer? You're going to have maybe something in your assessment that looks very quickly at level 1, like the first level, face to face with that person, about whether they're capable of self-advocating or whether they're going to need contact with an advocate, or whether they've got an informal advocate in a family member or a close friend. These things need to be taken into account, because if you don't know, if you're a provider who's never worked in this industry as anything more than a support worker, then you're not really going to know these things. And that is what I call the 2+2. That is how we've got to so much harm and so much money being spent without enough good outcomes, because people don't know what they're doing. I would really love to know what it would be like if we went back in time and the government decided, well, what we should do, because we're doing this brand new world of, closing down all our old services, where we had layer upon layer of management and governance. We should publish a policy and procedure manual, and then all these fact sheets, and they should have done that from 2013. 12, whatever day they opened. That's what they should have done. But instead of that, I'm very happy that I've got a business that writes policies, and really good policies, and teaches people how to do things. But really, from a taxpayer perspective, they should have published an incredibly good policy procedure manual and all the forms and templates, and they should have then put all the rest of the money they've wasted on other things into tons of training that was open for people all the time. Then we wouldn't have this billions of dollars that have gone down the drain for very little good outcome. There are some great outcomes, but they're associated usually with people who know what they're doing, or with people who may not have known what they're doing, but are very savvy anyway and have made an effort to learn what they're doing, or hire somebody who does. So, we need to talk about where it's documented that this conversation took place. These are some of the most basic things that, over a few years, I love to see how our providers grow. And if they keep in contact with us, if they keep having their internal audits with us, if they keep showing up to these, if they're on our learning management system where they can induct their staff and and also have professional development, use all of our courses. We watch them grow, and Ali and I just sit back and just marvel at some of our providers that have been with us since 2019 or maybe earlier. Some have only come in the last couple of years, some maybe just in the last 6 months. But we love to watch them grow, and it's just marvelous. It's just wonderful. But you won't grow if you're not exposed to lots of or frequent and regular upskilling and listening to how other people do things and hearing about what's changing in the market. So on this one, which is what the indicator actually demands of you, rather than cutting it out and verbatim, the audit test is if a staff member followed your procedure exactly, would the auditor's evidence checklist be satisfied? And really, it will be. If you've written it right, if you've written, a medication policy that says, go to the fridge and tip the medication into the puppy's bowl and then, put it in the lounge room. No, that's not going to work, is it? But if you've got it right and your procedure tells somebody how to do their job, double thumbs up, And let me tell you the other thing about that. Oh, look what Zoom did. It loved my thumbs up. That's so cool. Let me tell you the other thing about putting a procedure in. Also, you've got the fact that, how we talk about, you can buy a business, and if you've got to work in the business all the time, you've bought yourself a job. You're never going to be freed up if your staff aren't going to be able to work without you holding their hand or holding a manager's hand all the time. You need your policies to be empowering to your staff. You need your policies and procedures to be you when you're not around, or be that best person in your organization when you're not around. And the first thing that I say to someone when they ask me a question, whether it's in health or health, when I've worked in healthcare, disability, or drug and alcohol, doesn't matter where, they ask you a question. The easy thing to do is answer it, but then you've just made a rod for your back. The harder one, but the one that pays off, is to say, even though you know the answer, what does the policy and procedure say? And we don't have to say to them, "Oh, go and read the policy and procedure." I say it like, what does our policy and procedure say about that? I'm interested because, I think I've forgotten. You can just say something like that, which doesn't, however you manage that doesn't shame them in any way. And then they go and look. And that's what I say to everybody. And that's how you build capability in your organization. Nobody's going to sit there and read a policy and procedure. Some people will. I know one person. Shout out to Mel from Hunter Ethical Disability Services. Shout out to Mel. She'll sit down and read a policy and procedure when she starts a new job. God love her. And of course, she's become an auditor now. That's the kind of person that we want in auditing. But most people aren't going to do that. So the one way that you can build the capability of your staff is you do the slightly harder thing, and you say, instead of answering it, you do the slightly harder thing and you say, what does our policy and procedure say? I'm interested. And then they'll tell you, and you keep doing that. Yep. But you've got to make sure your policies and procedures are okay. You've got to. It's your job. Example 1, duty of care, medication management. It's expected that a support worker will be trained in medication management. It's expected that the trained employee will follow the 8 rights of medication. To not follow these rights would be a breach in duty of care and could result in legal liability should the participant be harmed. Okay, so this is a duty of care example using medication management. So why this statement works, it names the obligation, the medication management trainee. It's expected that the support worker will be trained in medication management. Number two, it names the standard the worker must follow, the 8 rights. It names the consequence. Sorry, guys. The consequence of non-compliance. This is really important. The breach of duty, the legal liability, and the participant's harm. An order can picture exactly what evidence they'd look for. Your training records, your medication logs, your competency assessments. You see, it's an art form, actually. I love policy writing so much. Too much, probably. And what genuine, I just got to move my Zoom heading. What genuine procedure looks like. What is a real procedure? Okay, example 2. Duty of care versus dignity of risk. Oh, this is one of my favorites. It's real. Learning to swim. Oops. A participant in SIL wants to learn to swim, but cannot swim. The policy shows how the person needs a 2-to-1 ratio for this, specialised equipment or instructors, risk management documentation to have been completed. Duty of care is met. Dignity of risk is respected. The procedure's pretty clear, okay? Because what we're trying to do is allow people that dignity of taking a risk and knowing that they could get hurt, but they're human beings, and if that's something that they want to do, we then weigh up, can we make it happen? So if we can, we will. And if we can't, if the risk is just too great to somebody, then we don't. Now, when I don't know who's when you're listening to this, if you've been around since day one, although I did not stay around for the rollout of the NDIS for a variety of reasons. I did hear about one of the first issues that somebody wanted to go swimming, and because it was all what's the choice and control? It was choice and control. So I was listening on the radio, and somebody drowned because somebody took somebody swimming, because it's choice and control, remember? And they died. And that kind of sums up some of my, a lot of where my feelings about the NDIS and how the government, like sequential governments, not just one, have managed this so poorly. So poorly. So yeah, so that's a lot of where I come from. One of the first things I heard. Choosing to smoke. GP advises the participant to quit. The participant chooses to continue. The policy tells staff, present resources to reduce smoking, ensure fire safety precautions are in place, respect that participant's decision. We don't want to be vague. We need concrete actions so the worker knows exactly what to do. It would be more in depth than this. I'm just doing examples of the way in which you want to make it clear to your staff. Yeah, really, really clear to your staff. If it's not there and a person doesn't really know their job, then anything can happen, and it does. We know that. We absolutely know that. Good policy equips the worker to apply the principle, not just recite it. The other thing I want to make really clear for you, it isn't an accident that the introduction of the NDIS made the category of employment called support worker, the second most dangerous in Australia. That's not just a coincidence. It's because of the nearly 300,000 providers, 21 or so of whom might be registered, 21,000, I mean. It's not an accident, it's a consequence. It's an unintended consequence of a piece of legislation and an implementation of a program that went south from day one. Okay. Level 3 policy just doesn't describe the obligation, it equips the worker for the moment. Let's have a look at this. I'm very sorry this has happened. I think we're talking about open disclosure policy here. So this is, how do you teach a staff member about open disclosure? That it's okay to say we're sorry when something goes wrong. Open disclosure, so it's giving staff the words. Level 3 policy would level 3 policy doesn't describe the obligation. It equips the worker for that very moment. I'm very sorry this has happened. I am sorry this hasn't turned out as expected. These are both good ways of saying it without taking liability for anything in that moment, because liability may not be known, okay? An open disclosure is that move towards apologizing for something, but you don't need to take liability for it unless liability is found. But just saying this to people is helpful for them and human. So 2 sentences. That's the difference between a support worker frozen in a moment of stress when somebody has fallen off a bike and hit their head or, anything like that, or fallen over, or because they weren't given the correct wheelchair, or they weren't given a mobility device, or the support worker didn't know they were in assisted mobility. So that's the difference between a support worker frozen in the moment of stress and one who has been equipped to respond. The audit test. If the staff member followed this procedure, would the auditor's evidence checklist be satisfied? Yeah, if your policy says that, if you've got training that talks about this, if you've got something in there, even if you don't have training, if you've had staff meetings where you talk about open disclosure, maybe once a year, you capture open disclosure. There are all different ways where you can demonstrate that you've passed knowledge on to someone. It might be a training module. It might be a policy read every month. Everybody reads through the policy, you critique it, you make changes in real time. That way there is no one time that you've got to do 5 days of work by reviewing policies, because you do it every month and you're passing that knowledge on to everybody and everyone's involved and engaged. The high risk gaps that I was talking about. So these are 5 areas of the most commonly deficient that we find at NDIS audits, the 5 most common deficiencies for high risk areas. In incident management, there's often a missing escalation pathway and the NDIS commission timeframes. Now, how do we see that played out? We see that with people who don't know that something had to be reported in 24 hours and therefore, a penalty occurs to the provider. We see that in people not knowing often as well what's an incident versus a complaint. We see that in people not being able to recite what reportable incidents are. There isn't a person working with a client face to face who shouldn't know what a reportable incident is. Complaints. We still find many people, and some are owners and some are managers. No distinction between feedback of what a formal complaint is and what a piece of feedback is. And they don't know their resolution timeframes either. Risk management. Some people will have a generic organizational register, and that might have all the business risk on it, but it may not mention a participant, like not a participant. It may not mention participants as a group, which should be on your customer in general, should have a risk element on a corporate risk register as well. And that should be documented in your policy and procedure, because you can't just kind of think about it like all those things and remember them. That's what policies and procedures are for. So it should be part of your aggregated risk management process, and also there should be a participant level register on its own. So one for corporate risk and one for participant risk. The aggregated ones, that is. Aggregated means grouped. So you might have a good way to explain aggregated is you may have 50 clients and you've got 50 risk assessments. Sorry, for those clients, all in their own client bundles. But what you need to do is take those 50 and write them in one document, not the whole thing, just the snapshot of the information, like what happened and the data happened and what you're going to do about it, etc., etc. So that's aggregated, having that snapshot of all of those 50 in that one place. So you've got oversight. And then restrictive practices is our fourth. No policy position, that's not uncommon, even for providers who don't use them. Yeah, I think people get a bit confused about, not actually, they're probably, some are confused and some aren't. Some people will take a module to a client and knowingly know they're not registered. They're not registered at all, or they're not registered for restrictive practices. And some people will be registered for 2A but have never even picked up the policy in their life. So it's not uncommon. And then the last one, the worker screening and training. This policy describes what should happen, but it doesn't match the actual practice records. So if your policy is saying one thing, but you're doing another, you've either got to figure out whether you're doing the right thing or the wrong thing, or your policy is saying the right thing or the wrong thing. And also I'll add to that, the best policy practice and the thing that will make your life the easiest is if you find a new way to do something that's still in keeping with the practice standards, it's just a different way, then the bottom line is you want to write that into your policy. But also, if you want the kudos and the congratulations and the history recorded for that, put it into your quality improvement register as well. Because, well, number one, you should be, because you're supposed to be doing quality improvement. But number two, it's such a perfect chronological history of all the improvements you've made. So if you're an employer and the owner, that's one thing. But if you're employed as a quality manager, I mean, I can remember 20 years ago when I went and found another job as a quality manager, I actually thought, oh, I'm going to just take all of those things I've done, because I've got them all in quality management registers over the last few years, and I'm going to just write my resume around those improvements I've made. It's outstanding to see what you've done, and you can do that for your organization as well in terms of a report. You don't have to be leaving and looking for another job. You might be your organization. You've got a fabulously populated continuous quality improvement register. And you could just write something really great about your organization using those. So these are the big ticket items, guys, where we see the 5 most gaps, and they're the big ticket items: incident, complaints, risk management, restrictive practice, and worker screening. They really are the big ticket items, aren't they? These are the ones where the most harm can occur. So these are the ones we want to get right the most. Now we want to talk about making policies work in practice, and that's what I'm all about. Policies have to work in practice or nobody will touch them. It's hard enough to get people to touch them unless they like them. If you find anyone who likes a policy, make them a quality manager, because if you like a policy, apart from the fact there's something wrong with you, like me, you'll make a great policy manager, a great quality manager. It's just an attribute that quality managers and compliance managers have. So anyone like that, keep your eyes open for them and nurture them into doing more quality and that finer detail stuff. So making policies work in practice. So the shelf policy problem, basically, and how to fix it. That's the sort of subtext for this. So you've bought something off the shelf. Some of them might need fixing, and some of them might just need making your own. For ours, we have a lot of examples in ours. So, I use examples over years so that people might understand things better. That you can still make ours your own. That doesn't stop you putting in your own parts and pieces. But we've also found people adapt the way that we say to do things as well. But yeah, make them your own or fix them if they're broken. In fact, if they're broken, take them back and ask for your money back. Um, Here's a case example when the policy isn't followed. A participant's auntie, an experienced NDIS auditor, terminated a support coordinator arrangement after 18 months of no progress records, no goal tracking, and passive service delivery. She requested a transition plan. The provider refused, sent multiple confusing emails, and burned through the remaining plan budget, arguing about that. The coordinator had to be paid from the auntie's own pocket. A formal complaint was lodged with the NDIS Commission. A transition plan is the right for every participant. It's a risk strategy to ensure that even if it's just support coordination, that the next support coordinator knows about what's happened with the last one. Do you know what? It's not fair not to do that because it takes a support coordinator about 2 to 5 hours to wrap their head around anyone, and there's 5 hours gone out of someone's plan. It's just not difficult. So that provider had transition policies. They just didn't follow it. That transition was discussed in their policies. They had a template for it. It wouldn't have been hard. They were just not a nice person or didn't care. So that's when policy isn't followed. And that cost that young man, the last 5 hours in his policy, in his plan, sorry. Linking policy to practice. This will make it easier for your staff. And as I say, if you want to bring those policies out of the laptop or off the shelf and into practice, one of the best ways to do it is in every staff meeting, the last thing that you have on the agenda is you go through one policy, and that way people are exposed to a policy each week, or whether it's weekly, bi-weekly, or monthly. You can work out the shape of what that looks like, but that's the best way to engage people in that. The other thing is when something isn't working for you, give someone an extra piece of work, like a small project to do while they're working, where they take on, we want to make this policy work for us better. Can you take that on? Can that, there's a little portfolio for you to work on. You can make their skills develop more and you'll get to see what they're made of as well. But also you rotate that around to other people so that everybody gets the opportunity to shine and you get work done, in addition to those things you just couldn't have done all by yourself because you don't have time. So linking policy to practice again. 3 connection points that turn a folder of documents into a working compliance system. The induction. Policies must be walked through, explained, and signed off, not emailed as a PDF attachment. Like I said, only people like me, Alison, Mel from Heads, shout out to Mel again, only people like us are going to read those policies. 95% of people are not going to read those policies, and you know it. And the sad part is that most companies know it, like HR companies and recruitment companies, but they've saved their ass by making them sign to say they have. So they don't care. But if it's your business, And even if you're a good provider as well, and a good person, you do care. You do want to make sure you're doing what's supposed to be done so that you don't get in trouble or your employer doesn't get in trouble. So, and you don't want to get anyone hurt either. So, induction, that's the touch point, the first touch point, exposure to your policies and procedures, which is why I wrote the mandatory onboarding modules. They're not all mandatory. I mean, we do have the mandatory, which is exactly what the standards say, and no more than that. But then I turned every one of the core module policies into a short learning module because I was just absolutely gobsmacked by how many people didn't have a clue, no, absolutely no clue what was in their core module policy and procedure module. And and I found that most amusing because I'd been an assessor for years before that in other standards before the NDIS. And I'd never come across an organization that hadn't read their policies and procedures. It just wasn't what we did. So yeah, I found that I was in awe of that. How could this happen? And I do remember that first NDIS audit that I did. It was the week before lockdown started. And I was so interested. The lovely woman, but she was asking me one question after the next, after the next. Like, honestly, I think I let her go all morning for like 3.5 hours asking lots of questions. And then I eventually said, do you know what? They're really good questions you're asking. I just want to like start with that. But I'm going to go out on a limb and say, I don't think that you've read your policies and procedures, have you? Because I have, and everything you've asked me is actually in them. And she went, no, I've never read them. So that was just so funny. That was just my introduction to the NDIS. Yeah, back in, what was it, 2020, I suppose. Yeah, I just thought that was really funny. Hadn't read them. It was easy just to ask me. So induction is point one. Supervision, two. Going over policies. What did you do there? Oh, you did a really good job with that. I just point out that wasn't in the policy. Maybe we could not do that, or maybe when someone has done something really good, you can say to them, maybe we could change our policy because I really liked what you did. We could add that. What a bonus. Touch point. Next touch point is the performance review. Staff knowledge and their application of the policy should be part of their performance review. Yeah. How they're interpreting the policies, if they're even following them in the first place. These are your 3 touch points. So what looks good? What good looks? What good looks like? What good looks like? And what to do next? Strong policies. Specific timeframes. They're going to say within 24 hours. They're going to say within 2 hours. They're going to give, 6 months. They're not going to say a generic language like a timely resolution. Doesn't tell people anything. Doesn't tell them anything. So we're going to say the timeframes expected under the practice standards, but also your timeframes. When do you want these back? For example, you might say, I want all incidents sent before you exit the building. So it might not be a time frame, it might be before you finish your shift, the last thing you do is look and see, were there any incidents or complaints that I have not sent to my line manager? Yeah. So it might be, has to be something there's no wriggle room for. Okay. No wriggle room. The names, you've got to put the roles, not people. Wouldn't put people. That's not a good idea because you're going to have to change them all the time. So put the roles and don't just say staff. A lot of them say staff. Silly, really, really silly. So we don't want to see staff. It's not saying who's responsible. We do need to know the position responsible. You know what? If you said staff and if you said timely resolution and something went wrong and you went to Fair Work to say, look what they did to me in my business, they'd go, well, you didn't give them any good policies. So no, it's on you. And they will, because your policies aren't good enough if they're saying generic answers like timely resolution or refer to staff or, any abstract kind of principles. So you want real work examples and scenarios. Try and avoid the abstract ones, like, you know, in a to a high level, you could put in, we want to see our participants or our vehicle having a checklist every end of every month so we can make sure it's maintenance and it's whatever. So on the 30th day of the month, instead of we need to keep a clean car, that won't, no one cares. No one cares about your clean car. They'll take notice if the policy says this and you have an audit sheet and you collect it, then they'll take notice. So you want something that links each policy to evidence it generates. So your policy might be around using the eight rights of medication. You may have a form, and it may be on your form that they go through the 8 rights. That's an example of linking what you're saying in your policy to the evidence. You might have, we will be giving our client a easy read welcome package, and you can say, please see, please refer to the welcome package, one in easy read, one in plain English, etc. So you want to talk about that evidence that is going to be used to do that task or part of that practice standard, or even part of the task that you're asking them to do outside of the practice standard, because otherwise it's far too wishy-washy for people to follow. Also, if you're not linking the evidence to something that you're saying you require and it's part of the practice standard, you will be pulled up and say the policy doesn't state what evidence, what they're going to use, etc. So, if you keep thinking like this person has never done this job before, what would I need to tell them? It will come out better. Giving staff the actual words to use will really assist, just like in the open disclosure, admitting when something goes wrong and apologizing for it, but not taking liability. So giving people words that they can use will be really helpful, especially when we see so many boundary breaches with staff. It's not, it can be people from non-English speaking backgrounds. It can be people from cultures that are very different to ours here in Australia. And we can have a lot of boundary breaches. So we need real words. We don't touch. We don't ask people out. We don't kiss. We don't hug. We need real words around certain things. It'll be different for different organizations depending on who your staffing are, but you'll know yourself. If you've had 2 incidents reports where, either a male or a female, either one has touched somebody in an inappropriate way, you need to start using the words that you want to see understood as well. So this is what really makes the policy and procedure an asset to you rather than this asset that you had to purchase and you don't use. It tells staff what to do if X happens, because otherwise they're going to do the best they can in whatever their head tells them to do. So wherever you can, and especially, you wouldn't get away with it now, except there are some auditors that unfortunately would let it pass. And that's the truth, because we wouldn't be seeing policies that still don't meet the standards when we know that provider's been to audit several times and we still get them and they're missing things. So there's obviously auditors who aren't really picking up or having a bad day. So it might, especially if it comes to what are you doing in this medical emergency? Now, we're talking about the medical emergency part of the practice standards that talks about for the person, and it requires you to know what their potential medical emergencies are, and then to have a list of things that your staff will do if each of those, or just that one, medical emergency occurs. So that is telling them X. Assessing, knowing what that person's medical emergency is, and saying what is the agreed action there. Otherwise, they don't know what to do. And we just have to know that most people don't know what to do. That will also work for many other things. If there are certain things that you want to happen, then you need to say X happens. Okay. So pretty much this is these are the ones that are most likely to cost your registration. The 5 gaps most likely to cost your registration. Incident management without escalation pathways and commission notification timeframes. A lot of those consecutively can cost your registration. Complaints, no distinction from feedback, no specific resolution times consistently can cost you your registration. 2 seconds. 3, risk management. If it's organizational level only and there's no participant level application of risk management, absolutely, repetitively can cost you your registration. It can also cost you registration because if you don't have that, the likelihood that your risk management processes are good is very low. And that could be the causal factor for losing your registration and somebody getting hurt. Restrictive practices. If there's no policy position, even for providers who don't use them, you still have to have, even if you don't do restrictive practices, as in you're not registered for 2A, you still have to talk about restrictive practices because they can happen all the time. They can happen, if a person's crossing the road or, they can happen. So you still need to discuss them and have them, in an emergency, it's okay if we need to do X, Y, Z. That would be on obviously rolled out with different people for different reasons, but it's a good thing to mention it, even if it's just so people don't use them. It could be because they might be used in an emergency, or it could be that people are using them without knowing it, like locking a door. Because you don't have anyone, you don't have 2A, you weren't aware that these things were going to happen. It should be in your policy anyway. Worker screening and training. Like I said, when your policy doesn't match your actual practice and it happens over and over again, and especially if somebody gets hurt and there is a history of it, of being picked up on those things. Okay. So what would you want to do next? All right. So if you're looking for policies and procedures, we have policies and procedures. We have core, we have verification, we have all of the high risk policies and procedures as well. We have quite comprehensive policies. They've been around now for about 6-7 years, 6-7 years, yeah. And we do provide updates to our policy purchases, and they're really good in terms of there's a little bit that you need to do to make them your own. Things like, council areas, we can't have one link for every council area. So just small things that, you might want to tailor, but we're quite happy to take people through that and show them. It also comes with our incredible forms and templates, which people love, and I can understand why, because they are very good and they do represent like 30 years of my social services and social services experience as well. We also have a compliance system, which we have 2. One is based in an Excel if you're not a software person, and the other one is the same model of compliance system, but we've built it into a software, and it isn't a billing software or a rostering. It's not rostering and billing. It is compliance. It's very affordable. It captures the compliance and quality for every area of NDIS service provision. And it works really well when you're using other softwares because this one captures all your blind spots. Um, we have a lot of people who are on, for example, ShiftCare, or they're on FlowLogic, or they're on Brevity, or they're on Halaxy. There are a ton, 360, I think there's one called as well, because theirs doesn't do what ours does. Ours is purely a governance software, and it really makes things quicker and makes your life easier as well and keeps everyone safer. So let us know if you, I'll put a link in the description or in the email for people I'm sending this out to. And let us know if you want to hear more about our quality and compliance tools and advice. And apart from that, want to thank you all for listening. And I do hope you take something away from this. Please reach out to us and subscribe to our YouTube channel, which is Effective Policy. And we'll all look forward to seeing you again. Thank you.